Hello dear students, welcome to another lecture of ENT recall series. Today we will discuss about cholestatoma. So what is cholestatoma? It can be defined as skin at the wrong side, but it is very non-academic definition. So we will describe it as presence of keratinizing squamous epithelium in the middle ear cleft. That is the definition of cholestatoma. It is made up of two parts. In the center there will be keratin debris, while at the periphery there will be a matrix. From where it gets originated, there are two theories. One is congenital origin and second is acquired origin. In the congenital origin, cholestatoma gets originated by the entrapment of squamous epithelium during the part of temporal bone development. Acquired origin can be again divided into two parts, that is primary and secondary. Now we will see each one of them one by one. First of all, coming to congenital cholestatoma, there are two criteria for the congenital cholestatoma. One is Clemmis criteria, second is Levinson criteria. So what are the points under Clemmis criteria for the diagnosis of congenital cholestatoma? First is cholestatoma will be seen behind the intact tympanic membrane. Okay, and also there should not be any previous history of otitis media. It is seen that it develops from the undifferentiated epithelium that gets converted into the squamous epithelium. So these are the 3 points that comes under the Clemmis criteria. Now coming to the second criteria of congenital cholestatoma, that is Levinson's criteria. What are the important points of this? First of all, a white chalky mass visualized just medial to the tympanic membrane. There should not be any history of previous otological surgery or procedure, and also there should not be any history of tympanic membrane perforation or ear discharge. On examination, there should be a normal tympanic membrane. Congenital cholestatoma contributes approximately 2% of all the cases. It is more aggressive. Why it is more aggressive? Because bones in children are more soft as compared to the adult bones. Common age of presentation is approximately 4 to 4.5 years. And what are the symptoms of congenital cholestatoma? It may cause facial paresis, conductive hearing loss. Why conductive hearing loss occurs? Because of the erosion of ossicles. And what are the important signs? On otoscopy, we will see a chalky white mass visualized behind an intact tympanic membrane. Okay, so that was all about the congenital cholestatoma. Now coming to the acquired origin of cholestatoma, as we have already discussed, acquired origin can again be divided into two categories, primary acquired and secondary acquired. So what is primary acquired cholestatoma? If there is no history of previous ear discharge, then it will be categorized into the primary acquired cholestatoma. What are the important theories related to this? Number one is pars flaccida invagination. What happens in this? Basically, there will be a negative middle ear pressure due to eustachian tube blockage, and due to persistent negative pressure, it will lead to the formation of retraction pocket, which accumulates keratin debris, which is covered by the matrix and leads to the formation of cholestatoma. Second is the basal cell hyperplasia theory. In this, there will be proliferation of basal cell layer of pars flaccida that will lead to the formation of cholestatoma. Third is the squamous metaplasia. So that was all about primary acquired cholestatoma and its important theories. Now coming to the secondary acquired cholestatoma. Why it is known as secondary acquired cholestatoma? Because in this the cholestatoma is seen in already diseased ear or in the ear with pre-existing tympanic membrane perforation or ear discharge. Okay. So what are the important theories related to this? First one is the migration of squamous epithelium. This states that the cholestatoma gets formed due to migration of squamous epithelium through the previously existing perforation. So basically the epithelial cells gets migrated from the perforation, it goes inside the middle ear, and where it gets accumulated and forms a keratin debris that gets covered by the matrix, and that leads to the formation of cholestatoma. Second is the metaplasia. So basically here we can describe metaplasia as the middle ear mucosa gets converted into the squamous epithelium. Why? Because of the repeated infection and repeated ear discharge that happens in the ear canal. So due to repeated infection and due to repeated exposure of discharge, the mucosa gets converted into epithelium. So that will lead to the formation of cholestatoma. So these are the 2 points that are important regarding the secondary acquired cholestatoma. Now coming to the theories of invasion of cholestatoma, what are the different mechanism of invasion? So the first theory that is discarded, that is the pressure necrosis theory. Why it is discarded? Because as we all know, the capillary perfusion pressure is approximately 25 millimeter of mercury, while the Cholestatoma, which is a white mass. So the pressure exerted by this white mass was seen approximately 10 to 11 millimeter of mercury in experimental conditions. So it is highly unlikely that this less pressure, that is approximately 10 to 11 millimeter of mercury, this is not able to compress the capillaries. So this will not lead to the bone ischemia or bone resorption. So that's why it gets discarded. There are few other theories also. Important one is enzymatic bone destruction theory. It is important because the cholestatoma or the granulation tissue surrounding the cholestatoma secretes certain enzymes. These enzymes are acid phosphatase, collagenase, acid protease, interleukin alpha 1, alpha 2, and TNF alpha beta. Other enzymes are also there, but these one are important. So this causes the enzymatic bone destruction, lysis of bone, that leads to the further osteitis and foul smelling discharge. Okay, so this was the accepted theory of invasion of cholestatoma. So now coming to the growth pattern of cholestatoma, what do we mean by growth pattern here? That is the route acquired by cholestatoma to spread in the middle ear cleft. The most common route acquired is via Prusac space. Okay, so there are certain other spaces also that gets involved, that is sinus tympani and facial recess. And at times, if the cholestatoma spreads to the anterior epitympana, it involves the facial nerve. So facial nerve dysfunction will also be a symptom of cholestatoma. What are the other symptoms? There will be ear discharge that will be very foul smelling. Why it will be foul smelling? Because of the bone erosion or osteitis, we can say. Discharge will be scanty in amount and it will be purulent in nature. Patient will also complain of hearing loss. It is also seen at times patient will tell that their hearing loss is much improved. Why it gets improved? Because there is a condition that is known as keratoma hearers. So what is keratoma hearers? The cholestatoma, that is a white mass that bridges the ossicular gap. Okay, so the ossicular chain that is made up of three bones, malleus, incus, and stapes, that gets eroded by the cholestatoma, but at times it is seen that cholestatoma fills that gap. So the conduction pathway is restored. So these patients will tell that their hearing is much improved. Okay, so these patients are known as keratoma hearers. So that was all about cholestatoma, its theories of origin, mechanism of invasion, route of spread, and symptoms. This will lead to a very important disease, that is squamosal type of chronic suppurative otitis media, that we will discuss in further lectures. So follow this channel for more such educational contents. Thank you very much.